Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your guest host, Adam Seidl, a shoulder and elbow surgeon at the University of Colorado. I'm here with Dr. Mark Kowalsky, shoulder and elbow surgeon at Orthopedic and Neurosurgery Specialists in Connecticut. Mark, welcome to the podcast, and thank you for helping me guest host.
Happy to be here. Thanks so much.
Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Colorado, or the institutions of any of our guests. Today we have an episode on an exciting topic in shoulder and elbow surgery and orthopedic surgery in general, the topic of mission work and international mission trips. To help us with this discussion, we brought on a couple of outstanding guests that everyone knows very well and have a ton of experience in mission work. The first is Dr. Javier Duralde, immediate past president of ASES and orthopedic shoulder and elbow surgeon at Peachtree Orthopedics in Atlanta. Dr. Duralde, welcome to the podcast.
Adam, thanks for having me.
Next, we have Dr. Sean O'Driscoll, shoulder and elbow expert from the Mayo Clinic. Dr. O'Driscoll, thanks for joining us on the podcast.
Thank you, Adam. Pleased to be here.
All right, let's get to it. So I want to start by hearing about some of the mission work that both of you have done and been involved in. As we're planning this podcast, we surveyed many shoulder and elbow colleagues, and your names, I have to say, just kept coming up over and over again as people involved in this work. So why don't we start with you, Javier? Why don't you give us a little bit of your background with this type of work?
Great. So I started mission work in 1998, started going to Haiti, and I've been going whenever it's been safe enough to go for the last 20 years. Our group, Peachtree Orthopedics, started going there in the 1950s, and we've continuously been providing orthopedic care for the Hôpital Albert Schweitzer in the Artibonite Valley in Deschapelles, Haiti. And so that's the majority of my mission work has been down there. I've also started in the last couple of years gone to Cuba a couple of times, which is slightly different because Cuba is obviously more sophisticated than Haiti, and it's been sort of a different type of mission, much more focused on education as well. But those were the two main missions that I've been going to, and the Haiti mission obviously is very much third world, and there's limitations on what you can do because of equipment restrictions and that sort of thing. But this type of work really opens your eyes up to how good we have in the United States, and it also helps you expand your horizons because you start to see the kind of pathology in other countries that you just don't see here.
That's outstanding, Javier. Thank you for that. Sean, why don't you speak to your experiences?
Yeah, thanks, Adam. I have been interested in missions for many, many years, and like some people I have spoken with about this, there were quite a number of years that elapsed before I actually put it into practice. And so I have been working in the mission field on and off for 11 years, mostly in Africa, in a number of countries in Africa. But also I've been to Haiti a few times. Javier, I haven't been together with you, but I was really interested to hear your experience. And also Asia, China, Thailand. So it's been varied, and some of it has been very more orthopedic in my area. Some of it has been more general medical and orthopedic.
That's great. Well, thanks for your thoughts and experience. I think there are so many of our members that are going to be interested in learning from the both of you. I'm curious if we harken back to those early days, Javier and Sean, 11 years ago. What was it about medical service internationally that interested you? And looking forward back then, what were you hoping to gain from the experience?
Well, I'll start. Our group had been going there for 40 years by the time I got there, and it really, from a selfish standpoint, it was a real form of camaraderie in our group. People bonded, in adversity. Sort of like when you're residents, you bond in adversity. going to Haiti, and there's always, great stories and, all kinds of, difficulties that were overcome and things like that occurred during the trips that always seemed very interesting. I was interested in challenging myself, going to a place where they had different type of problems with equipment that was inferior to what I was used to using, and so that you had to have sort of a MacGyver kind of mentality to be able to succeed there. But I guess the bottom line is the realization that we are so fortunate to be in the United States. And in the words of Warren Buffett, says if you were born in the United States, you've really, and a couple other things, you really won the lottery ticket. And in Haiti, it's the poorest country in the Western Hemisphere, and those people just really have nothing. And so to be able to go down there and help them was just very important to me. And I think it's the sense that there's a large part of the population of the globe that doesn't have adequate health care available to them, especially specialized areas such as orthopedics. It's estimated that 2/3 of the world's population doesn't have adequate orthopedic care. And so I think all of us went into medicine because we wanted to help people, and this is an opportunity to really help people a lot. And it takes a certain mentality to go down there and do it. But it's a typical story of you gain more than you give when you go on one of these mission trips.
Yeah, I agree completely with that last statement, Javier. I decided when I was in the 9th grade in high school that I wanted to at least spend some years in the future as a missionary doctor in Africa. As I mentioned earlier, that didn't materialize in the early times of my practice. And by the time I actually set out to do so, I had become rather subspecialized to the point that I really wondered whether I had anything to offer whatsoever. And that turned out to have been a fortunate thing in a way, because I didn't go with any sense of what I had to offer. I went with a sense of what I needed to learn about how we could help and what the needs were. And so I planned on doing 5 very different mission trips in different parts of the world before I would really try to decide what I thought maybe my role would be. And that was very fortunate, because I learned a lot that I wouldn't have learned otherwise, I think. My saying became, I do elbow surgery, principally elbow and shoulder, but my saying became, it's not about the elbow. Or if I was in a place where it wasn't about elbow surgery and it was open tibia fracture, I would say, it's not about the open tibia. So the bigger picture became really important to me. And I've learned that the relationships that we establish and the support that we have in an ongoing way, even day to day, when we're back here supporting people in the mission field, has become one of the highest priorities.
That's outstanding. So, one of the things that I think about is, and Sean, you touched on this, is how subspecialized we all are. And, one of the things I wondered, and you talked a little bit about it, but what are as a shoulder and elbow surgeon, what are the most common surgeries that you're doing on these trips? And obviously it looks like you've expanded beyond shoulder and elbow surgery in those trips, but within the field of shoulder and elbow surgery, what are you doing when you're doing these mission trips?
Yeah, so I go to a variety of places, and as a result of that, the spectrum of what I do when I'm there is quite great, quite great, probably greater than the spectrum of what I do here. So there are a couple of places that I go to, one in China, one in Ethiopia, where I have been mentoring one or more surgeons, and have been doing so for between 7 and might be in the range of 8 or 9 years on a continuous basis. And so surgery that I do in either of those places ranges from just very, very complex stuff that we wouldn't even see here normally to very, very specialized. And so that's at one end of the spectrum. If I go to Guinea, which I go to on a recurring basis, it's at the very opposite end of the spectrum. I spend a lot of my time there teaching or maybe reteaching people how to tie surgical knots. the importance of scrubbing your hands, these sorts of things, and leave pearls that I can, whether they're general orthopedic principles about managing a tibia or femoral fracture with a sign nail, or very specifically about an elbow. And a lot of times it's things like, how do you salvage a bad elbow fracture dislocation when you have the smallest implant you have is a 3.5 screw, and you have few plates and no prostheses and so on. So how do you deal with that? And I really enjoy that challenge, just like Javier, you were saying about how you really have to learn to improvise.
Yeah, Adam, it really depends on where you go, what you can do. So, like when I've been to Cuba, they do have arthroscopy there. And so when I've gone, I've taken all my anchors and my instrumentation with me. And, at one point I was, it was funny. I was repairing a small rotator cuff there arthroscopically. And I joked, it was like showing fire to the cavemen. They were so impressed with my surgical skills. I felt good about myself that day. But they said, well, we don't have a suture passer. So then I had to say, okay, well, let me show you how to do it without it. So you have to sort of modify your techniques to what's available to them there. When you go to the third world, it's very different because the problems that you see there often have to do with old trauma, congenital and developmental defects. Like in Haiti, there's a lot of rickets, for instance, and then osteomyelitis, which we're not used to seeing here. And so those are the type of problems that you have to sort of grade in your mind of how serious is this, how important is this, and what am I going to do? And frankly, in Haiti, we treat rotator cuff problems with Motrin because really compared to the other problems that we see there, that just doesn't reach the level where you say it's worth trying to operate. Plus, you don't have physical therapy, you don't have arthroscopy, so it'll be all open surgery. And so a lot of it's trauma that you're taking care of in the third world. And again, just like Sean said, you're often, you're measuring for your screws on your plate, and you say, 16. They go, no 16, and then you go, well, what's close? 20. All right, I'll take 20. So your X-rays don't look so great afterwards, but you get the job done, and so you have to be ready to adjust your techniques for the problems that are in the area in that particular area. And then you have to temper your enthusiasm. You have to do the best that can be done with the available equipment in that area. And the first couple of years, the group I went with in Haiti, and it's interesting because Danny Guy went down there with me for many, many years. We got to be close friends, so it was nice when he was president of the academy. I was president of Shoulder and Elbow. We spent so much time together in Haiti. It was very easy to communicate. But the first few years we went down there, we got ourselves into trouble. We've been in the middle of an operation. We realized we really didn't have the equipment to complete it the way we'd planned it. And then as years went by, we developed a much better concept of what's feasible in that environment. And then we could do it, So I think that's one of the benefits of going back to a place like that. And, there's a steep learning curve. But once you start feeling comfortable in that environment with those particular problems, and with the equipment you've got available to you, then you'll get in and out of surgery much better.
Yeah, you bring up something really
great. Oh, go ahead, Sean.
I was just going to emphasize something that Javier just said, because you bring up this aspect of having to adapt to the circumstances. And, one of the things that I have learned is that when we go to the mission field, we really should best be focused on what the needs are there, not what ideas we have about how we can improve it. And one of the greatest needs is to essentially mentor the surgeons there on how to learn. And so going there, not with our own equipment and things like that, but going there and being ready to deal with the problems with what they have available to them is something that requires us to learn in real time. And they really greatly appreciate and benefit from that when they see us figure out what we would do if we were working in their circumstance, because that's where we are at the moment. And so that's a really good point you bring up. And I completely agree that being prepared to adapt and teach them how we might adapt if we were there full time is really a very key thing.
That's great. I think it sort of dovetails with a conversation of how to evaluate an opportunity when one's thinking about beginning medical service abroad. You've talked about consistency, Javier going to the same place multiple times to gain a comfort level, and Sean's talked about identifying the needs of that community and catering to the needs. Are there other must-haves or critical issues to keep in mind when you're assessing opportunities for medical service abroad and organizations that you're looking to collaborate with?
Well, it's interesting, that we have not been able to go to Haiti now for the last 3 to 4 years because it's been too dangerous. And it's heartbreaking because the people that suffer are not the people that are causing the problem in the first place. And so there's a huge interest in our group to continue mission work, and so we started working. One of our total joint surgeons has been working with a group called One World. And they're sort of like Operation Walk or something. I can't remember some name like that. That has a similar sort of thing, similar sort of a process, and it's a little bit different because they go to different places in South America and the Caribbean, and they take an entire team with them. So the entire OR staff, pre-op, post-op, and then they take tons of total joints, and they'll go do 30 total joints in a week in a place. And usually the hospital has one surgeon there who can do all the post-op care for you and that sort of thing. And it's sort of a different concept. But so there are organizations like One World and Operation Walk that you could look at, and they've done primarily lower extremity, like total knee, total hip type of procedures. But I'm sure that something like that could be organized for the shoulder as well. Otherwise, it's kind of hard. I mean, we've always had this relationship with the hospital down in Haiti that our founding partner started in the 50s, so we were lucky in that sense of being able to find them and get along with them. I met the president of the Cuban Orthopedic Society at one of the meetings I was speaking at in Mexico, and he told me that they were having a big push for minimally invasive surgery, invited me to Cuba, and that's how I started going to Cuba. And we did go do an academy trip down there as well. Same idea as sort of teaching. So I think Sean, maybe you could comment on that, on how you found out all these different places you've gone to.
Yeah. So I think that one, maybe, there are several factors that are bigger factors when you're thinking about where you might go or what you might do. One of them is that mission work is broadly divided into faith-based mission work and secular mission work. They can look the very same in the field potentially, or the content of what you do there. The work that you do can be the same, but the overarching purpose is in one case is very related to faith. In another, it's only related to what you're doing. It's humanitarian. So that would be an important thing. And I would encourage people to try to think in their minds, are they interested in one or the other or both? I do both types of mission work. So that'd be the first thing. The second thing would be to, I would encourage people to not necessarily spend too much time worrying about or thinking about what your skills are that you bring, but rather finding out what the needs are and then what you might be able to contribute as a result of that match, because they may be very different. When we go with the idea of helping in a certain way, we often end up generating a phenomenon that's known in the mission world, that's referred to as helping, or that you want to avoid, which is helping without hurting. And so we want to go and help without hurting. I said avoid. I'm sorry. I meant do. I got mixed up there. But you want to help without hurting, and we can inadvertently create a great deal of dependency in our mission work, and that's obviously an undesirable side effect of it. So it would be important to try to get a sense for that aspect of it by talking with people who are quite experienced in the field, and very much so with the people who are at the destination you wish to go to. And there are a lot of places. There are places all over the world that desperately need people. If there was a lineup of people wanting to buy a plane ticket and ready to go, we could arrange those things and establish connections with people.
There is an international committee of the AOS that may have some connections as well in terms of what places to go. The head of that committee is Guido Mara for a long time. He's rotated off of that, but he's an ASES member from Chicago, and he's been involved with doing a lot of work. He's been going to Romania many times over the years doing mission work there, and really has elevated the whole level of shoulder care that's been provided in Romania. Just to dovetail on one of the things that Sean said, it's very important, when you first go on a mission trip, you say, oh, I'm going to save the world, and you show up there and you're eager beaver, and it's just another week for them. You have to realize that you're depending on the anesthesia staff, the nursing staff, the patients, all that sort of stuff. And you're there to help them, and you need to work within their system. And that's how you can help the most, not come with preconceived ideas. And you don't really want to underestimate the commitment or the intelligence or, the motivation or skills of the people who are there. I mean, they're trying to do a good job, and they can often teach you some things about how to deal with problems in that area, just because they've been dealing with a limited kind of hardware availability, and they often come up with ingenious ideas that we hadn't thought of because we've got every, trick in the book, available to us in our own hospitals.
I think that those are great points. I love that, helping without hurting. And I think one of the things that you think about in our practices here in the U.S. is our follow-up, and how are we seeing these patients. And we're all, I think, very prideful as far as seeing our outcomes and seeing how patients do. So how do you handle that with this type of work? And I know obviously it's dependent on the setup and who follows your patients, but how do you follow that from a logistics standpoint at certain locations, but also, how do you handle that mentally, not knowing how your patients are doing, or do you get that information from orthopedic surgeons at the locations that you travel to? Javier, if you want to comment on that.
Yeah, so the hospital in Haiti has general surgeons, and so there's a general surgeon there that we depend on a lot for our follow-up. We would communicate, and back in the 90s, early 2000s, there was no internet, and so we just we sent 3 teams a year, and so the next team would give you your follow-up, because Dr. XA was following the patients, and he'd tell you, and then you'd give the patients follow-up for when the next trip was coming, so that your colleagues would see that patient when they got back. With the internet now, we can even get X-rays sent to us, from Haiti to look at. But it is difficult, and you find yourself trying to do operations that don't require any kind of intensive physical therapy, because they just don't have access to that. And I mean, literally, people are riding donkeys to come to the clinic. It's crazy. The things that happen. The first trip I went on, I'm there, and the guy comes to me, and he's got a contusion of his hand. A rock fell on it. So got X-rays that look okay, and I'm sitting there with a translator, and I'm telling him, well, I think it's just a contusion. I think you're going to be okay. Just put some ice on it, and you'll be okay. And then the two of them are going back and forth, back and forth, back and forth. I'm saying, boy, they're talking a lot for this kind of translation. And then the guy turns to me and goes, where would he get ice? And then I realized they've got no electricity there. They've got no ice. So some of the common things you think of are just normal treatments, aren't valid there. So, you got to kind of like adjust your thinking to what's available there. But it's all part of that same concept of adjusting what kind of treatments you offer patients, because that the follow-up is going to be limited, physical therapy is going to be limited.
And Sean, I guess we can take that question to the next step. Is some of these locations that you're going to, you're doing surgeries that are quite complex and treating some pretty severe conditions. How do you deal with a complication if you have it?
Yeah, so good question, because they're going to happen for sure. So if I'm aware that if there are complications immediately, if they're operative or immediately post-operative, then I would deal with that in the same manner that I would here with the limitations of the circumstances there. So that I think is a more general response to that question. But complications that show up after we're no longer there, I then just advise a surgeon. I have good communication with the surgeons I work with. Advise a surgeon. We go back and forth by email or WhatsApp or other mechanisms, and as to what I think might best be done. There will be times when perhaps I don't know about the complications at all. That obviously is a likelihood that can happen. How we deal with it, you or Mark had asked earlier, psychologically or mentally, that's very important. I think it's an extremely important thing to think about. And I think that develops with time. Maybe Javier, over time, you might have felt that was something that developed for you, or maybe some people have it right away. But it can be difficult, and it's an important thing to I think, be intentional about acquiring the I wouldn't call them skills, or their intrapersonal skills to manage those situations. But that requires and is readily available to deliver to you humility. And some of the things that Javier was saying, and many others, really rapidly confront you with the need for humility. We really need to check our pride in the parking lot at the airport before we board the plane, because if we don't, we're in for trouble, quite frankly. So dependence on yourself is not a good idea.
Yeah, I think that's a great way to say it, Sean. That humility is so important when you go there, because you're doing your best and you're giving people care that they otherwise wouldn't have. And when I mentioned earlier we were trying to do too much, often you're putting in hardware without fluoro, for instance, because you just don't have fluoro. And so we would get x-rays after surgery, then find we had intra-articular hardware. So the first case the next day was to remove that one screw that was a little bit too long, which was kind of humbling to do that. We had 1 week where we had seemed like it happened every day, and so it was a different joint. And we say, we're joking with one of the doctors that he's going for the cycle, because he left the hardware in every joint in the body, by the time we left, and so, so it's crazy, because one year we got there and they go, "Oh, thank God you're here. We have a patient here who's got Pott's disease, and he's progressively paralytic, and he had like a T7, abscess." And so we all look at each other, and the three of us who were there were a hand surgeon, a total joint surgeon, and me, a shoulder surgeon. And we're all like, "Oh my God, what are we going to do?" So, and we had a resident with us. And so we got Campbell's out, we got the book, when we put the patient prone, and we were able to evacuate this, big abscess and stuff. But it's a little scary, and you worry you're going to kill somebody. So it's something you have to tell yourself, I'm doing the best I can. I'm helping these people, and some things aren't going to go the way I want. There's another case that it wasn't an operative case, but I had a patient comes in, and he had this huge osteosarcoma of his distal femur. And then, I palpated his groin. He had positive lymph nodes. And he said, "Well, what should we do?" I said, "Well, really nothing to do. Just use put him on crutches. Be careful. Don't," because there's nothing to offer the guy. There was no chemotherapy there. There was no kind of, radiation, nothing available. And the guy was a goner, but, all you could tell him was, use crutches, be careful. The bone might break if you're not careful, but there's no other treatment to offer, and that sort of gets you right in the gut, because you realize the kind of treatments we have available to us in the United States and just not available there.
Yeah, these are some heavy intellectual and emotional issues, and we've talked about the complex cases that you tackle. I guess on behalf of our youngest members, as you look back and look forward, how do you think interested surgeons should consider timing of medical service abroad? They're obviously going to be balancing, starting a new practice, trying to get research off the ground if that's an interest of yours, and then an interest in medical service. What's the ideal timing, or the right timing, to get this type of work started after you leave training?
Sean, why don't you take that one?
Well, I think we almost did it from opposite directions, Javier and me, because you started in right away, and I had this desire to do so, and there were a number of things reasons for which I ended up not. I think there turned out to be a real benefit for me that by the time I did, I was already so specialized, because that really opened my eyes to things that I think I would have been blind to. But my recommendation to people is to go as soon as you possibly can, because the big barrier for most people is actually picking a range of dates that they're going to go and buying a plane ticket, um, meaning that they're now going. And so I've learned that there are countless of our colleagues and friends who would love to do this. And so one of the roles I have right now is bringing people into the mission field, and I do that on a kind of one-on-one basis. And every single one has, really found that to be the launch of for them the interest in missions and put into practice. So I would encourage you, if you're interested, to talk to somebody who's involved and say, hey, listen, I'd like to go on a mission trip, and just go. Don't try to customize it to anything personal about yourself. I would say it's good if you can go with an attitude that it's not about me. That's a really good attitude to go with. It's not about me. And so do it early, I think.
I would agree with that. Do it early, because especially, during your residency, you've had to sort of figure out a lot of things, and you've got the latest, greatest sort of techniques under your belt. And one other factor I think kind of dovetails into what Sean just said is that many of us have brought our children on these mission trips, especially they get to high school, college age. And this really opens their eyes to the world, to see, what the third world is like, and how lucky they are to be in the United States, and I think it fosters a sense of desire to continue to do mission trips in younger adults, and so that's another added benefit of it. So I think the sooner you do it, the better. Really, it's like a week away from the office. Most of the time, depends if you're going to China or Thailand, it may be longer, but certainly the Caribbean, Central America, you could go down there for a week and come back, and it's not that much time away from the office. And it's unbelievable the benefits you get from going, not only the help you're giving people, but what you learn and how you grow as a person, how you grow in your faith. I think that's very important too, what Sean was saying.
I mean, I think those are great points. I think it's very, it's interesting. As Sean alluded to, you guys kind of had very different approaches to this. Javier, you got very involved early on, and Sean, you waited till you were well into your career. So I think, I think there's hope for all of us that you can take either approach. And even later, I am personally going on my first mission trip coming up in December to Honduras. And, just kind of out of luck, we hired a hand faculty member who was heavily involved in that in the past. And I'm kind of just latching on to his group and going down for the first time. But it's something that I've, honestly, I've thought about since I was a resident as far as getting involved. And I think the longer you wait, the harder it can be with all of our busy schedules, families, and so forth. So I personally wish I would have done it sooner, but I do think for those that haven't done it, I think the take home, and Sean can say this as well, is that you can still do it later on or several years into your career. So I appreciate that.
I think one of the things to keep in mind is, my first job in orthopedics was military. It was the Air Force. And I was frustrated in the Air Force in that not being able to be as efficient as I wanted to be, because somebody controlled my resources, didn't let me do as many cases as I wanted to, see as many patients as I wanted to, that sort of thing. And so I've always been someone that's tried to pack in as much work as I could in the briefest period of time and really just be super efficient. And then you go to a place like Haiti and you can't be efficient. It's extremely frustrating because you're working in their system. And I came back from my first or second trip and I was extremely frustrated. And I was thinking to myself, God, I don't know if I want to go back there. It's so frustrating to go down there and not really be able to get everything done that you want to get done. And they don't really, appreciate us, blah, blah, blah. And I was in the doctor's lounge between cases, and there's a plastic surgeon there who had done a lot of mission trips. And he said just what Sean said. He goes, it's not about you. It's about them. You're going down there to help them and you have to work in their system and not go down there with preconceived notions. And I'm kind of a firm believer that sometimes God talks to you through people, and that was God talking to me right there saying, get over it, keep going. And that was like the second or third time I'd gone, and I went a lot more in another 20 years, and a lot of it was just sort of my eyes were opened at that point, like, yeah, it's not about me, it's about them.
I would maybe dovetail into that in a way that I mentioned earlier that, broadly speaking, missions are either faith-based or humanitarian, non-faith-based. For those of you who would be interested in faith-based missions, how you just said, it strengthens your faith. I would say to you that it is probably one of the most profound ways in which you can challenge yourself and be confronted in your faith, and the most profound ways in which you end up growing as a result of it. So to experience, for example, dependence on God as a surgeon, and you're normally dependent on maybe your team and yourself and your instruments and so on, which we are in the places where we work. But to be willing to be dependent on God reveals things to you that you just may not ever experience in life any other way. So I go with the full expectation, and this is, by the way, whether this is a faith-based mission or not. So I go to very secular places, but I go there with the full expectation that I'm going to come back just marveling at how I saw God work. And it's just an incredible joy. For those for whom faith would not be a component of it, I would encourage you to see if you can have an opportunity to witness what that's like in a faith-based mission, not for the purpose of changing your faith, but for the purpose of seeing what it's like there, because humility is evident everywhere, and dependence on factors other than yourself is clearly abundant. And it's an incredible experience for anyone, regardless. So I've brought people of non-faith to places, and many places will regularly accept somebody for whom faith is not part of it, as long as they understand that that's a big part of the mission itself.
The people there are so grateful. We used to joke that, in Haiti, you'd say, you need surgery, and they'd say, thank you. And, here, you'd say to the patient, you need surgery, and they're like, well, what are my other options? And I think I need a second opinion. And could you refer me to somebody better than you? Things like that. It's like, it's a night and day difference in terms of the gratitude the patients have there for what you're offering.
I think that's great. You both talk about bringing your whole selves to the project, whether it's faith-based or not. And I guess I would just ask, maybe sort of in a moment of introspection, is there something that you've learned about yourself on these missions and service trips? You've talked about sort of the camaraderie you get, the exposure to pathology, the respect for the patients and communities in which you work, but are there lessons or things that you've learned about yourself that you brought back to your work and family at home through this experience?
Well, I think for me, it's I've learned how lucky I am, and all the opportunities that I've had to get to where I am right now, and how you can't take those things for granted. In Haiti, there's not a street that doesn't have potholes in it. When your wife picks you up from the airport and you drive on a smooth road back home, just that by itself is a gift. And you just realize everything about your life has been so fortunate that that you need to complain a little less, and you need to give people a break, and not be critical, and just be thankful for everything that you've gotten, and be a little bit more understanding in terms of what other people don't have. And I think, from a social standpoint in our country, we have, here we are going overseas to help people, and there certainly are a lot of people in the United States that need help as well. And we don't have a good mechanism to do that, in our current system. And so, I think you gain empathy when you see the position people are in, and you become more thankful too, because you just realize that you have a lot to be thankful for.
Yeah, I agree. I was thinking there's a really good question. I think that one of the greatest things that I have experienced and learned is that I think people who would be with me would say that I'm a very much better person when I'm in the mission field. Um, I think what it has to do with is that when I have no control over the situation and I'm just dependent on the resources there, the people there, and God, um, I- aspects of my nature come out that generally might not come out when I am in control, when I have the right to be impatient with somebody, if you know what I mean. Saying that tongue in cheek, but it really brings out aspects of character that um, we might be a little bit less likely to experience here. And so I'm not sure that I've been able to express that very well. Um, but we grow as we, especially as we become perhaps as we rise up in our careers, we become somewhat, shall we say, entitled in our minds. We become entitled to proper technique in the OR, entitled to time efficiency, entitled to a lot of things. And when we go to somewhere like we've just been speaking about, we're not entitled to anything. And for you to really contribute and feel that you have left that place a better place and helped the people to be better off when you have entitlement to nothing there requires a very different approach. And as you experience how to do that, you feel a much greater level of joy. So I always come back a more joyful person. I think I've really changed as a result of that. And Javier mentioned bringing your family. I brought all my family, all my kids to the mission field, both as a family and individually. And that's been life changing for them. I started when they were about 13. So I would encourage you to take your families as well.
Yeah, I think
Well,
a couple of points is to add to that is one is you really have to have the attitude, I'm going to go and help some people and I'm going to go home. And it's sad. I mean, I've been heartbroken sometimes on the flight back thinking about the people we didn't get around to treating because we ran out of time. And you just have to have that attitude. I'm going to go help some people. You're not going to change their system. You're not going to change the world. But if you can just help a few people, that makes a difference. So you have to be willing to accept that and accept the fact that you can't help everybody. The other thing, though, is that we get very specialized in the shoulder world. And I had one year where normally with 3 surgeons all went down together, and we could handle clinic and surgery and all that sort of stuff. At the last minute, something happened where I had to go down by myself, and it was like suddenly I had to handle clinics and surgery and everything by myself. And I would joke that I was standing in front of the mirror each morning, and I said, tell myself, I'm the best orthopedic surgeon in this country. And then I'd go tackle whatever I could do, and you realize you could still do a lot of other, cases other than the shoulder.
so those are awesome comments. So I think we're winding down on time. So I just want to tell you both, Javier and Sean, thank you guys so much for coming on and sharing your experiences. I think this will be so helpful for all the listeners and those interested in doing this work in the future. Hearing these experiences, hearing your thoughts on this process and the work that you've done, I think is outstanding. So I also want to thank you, Mark, for helping me co-host, and for all our shoulder and elbow listeners out there. Don't forget to subscribe. And on behalf of the regular ASES podcast hosts, Pete Chalmers and Rachel Frank, I'm Adam Seidl, and we will see you next time.